A webinar.
Okay, good morning everybody, and a big welcome to this webinar on the Better Care Fund's Disabled Facilities Grant and Evidencing Your Impact. I hope this is where you were expected to be, and wherever you are in the country. I hope the weather's kind of not too bad. It's a bit dull and cloudy down here, and remember, you know, you can be eating your sandwiches during this webinar and we'll be none the wiser, so that's fine. My name's Tony Hunter. I'm the Chief Executive here at the Social Care Institute for Excellence, and delighted to be hosting this webinar. So what we're looking at is how disabled facilities can be used more flexibly to meet Better Care Fund objectives, and into performance metrics and how they can be used to review and to improve delivery. And I'm really pleased that we've got Paul Smith here, the Director of Foundations, which is the national body for home improvement agencies. He's going to present, and he's one of the authors of the Independent Review of Disabled Facilities Grants published last year by the Department of Health and Social Care and the Ministry of Housing, Communities and Local Government. Logistics, it's planned this webinar, as you know, it's going to run for an hour, but we'll try and finish maybe 5 minutes earlier, so just to give you that breather before whatever you're doing at 1 o'clock. As we go along, ask questions by making comments to Paul and indeed other participants by typing messages in that chat box that appears on the screen and then hitting that return button, maybe not too hard. Don't look for video because there isn't any. That's kind of sometimes happens, can be a distraction. I know Paul and I are very keen that this session is very interactive. You know, Paul will probably pause now and again. We'll also try and pick up interesting themes that are arising from the questions and comments that you're making. So we'll do our best on that. We're recording, finally from me, we're recording the webinar, and we're going to be putting it on the SCIE, Social Care Institute for Excellence website afterwards, along with your questions and comments. Some of you will make useful connections with each other as well that you'll pursue outside, and that's great. And we'll also be including the presentation material itself. Okay, so I hope that's fine. So with no further ado, I'm going to hand over to Paul. Welcome, Paul.
Thank you. Hello, everybody. So we're going to talk about self-facilities grants and evidencing your impact, and particularly how you can use those that evidence of impact to improve your services going forwards. If you don't know us, Foundation is National Body for Home Improvement Agencies, something we've done since 2000. And our remit includes supporting local authorities with improving their delivery of disabled facilities grants and DFGs. So please feel free to get in touch afterwards if there's anything that's particularly interesting today. So during the next 55 minutes or so, we'll see where DFG sits in terms of integration of housing, health, social care, recognising the opportunities to use DFG more flexibly, and if we can use the right metrics, how we can measure impact and develop a theory of change. Because one of the things that we recommended as part of the DFG review, and it was published in December, was that each local authority should have a transformation fund, and how you use that transformation fund will be particularly key in obviously how you improve services, and I think the metrics that you measure will be key in terms of how you can use that. So just a quick overview of the review that was published in 2018. It came as a result of a Communities and Local Government Select Committee. They reviewed or had evidence around disabled facilities grants, and that suggested that it was slow, cumbersome, and some people doubted it was always good value for money. And they said that it should be reviewed, and in particular they were troubled by the split in responsibility between district and county councils, between housing and social care departments, and how that impacted on delivery of adaptations for disabled people. So the review was commissioned by Department of Health and Social Care, working with the Ministry of Housing and Local Government, and what we were asked to do was look at how DFG is currently being used and then make recommendations for how it could function in the future. It was led by University of West of England, working with ourselves, BRE and Ferret Information Systems. And the key thing across all of it was that DFG was the missed link. So it kind of joins up a wide variety of policy and operational issues. So disabled facilities grants are funded by the Department of Health and Social Care, but policy is produced by the Ministry of Housing, Communities and Local Governments, and DFG is there, the link between them. The Care Act has requirements for collaboration around home adaptations and requirements for social care to fund adaptations under £1,000. Housing Grants Construction and Regeneration Act talks about adaptations over 1,000. And again, kind of the link between them is DFG. Support for disabled people. If you want to stay living independently at home, there'll be some services from county councils, some services from district councils. And again, they both input into DFG. Social services and housing departments, equally getting both involved. And on the ground, it's usually occupational therapists that assess what's needed for a DFG, and then either a home improvement agency or an adaptations team that deliver it. Again, both are required to deliver DFG successfully. So the recommendation we made, recognising all that, was that there should be a strategic partnership between housing, health and social care that recognises the knowledge and expertise of both. And we called it the Goldilocks option because it was just right. It wasn't too much housing, wasn't too much social care, just kind of in the middle somewhere. And it wouldn't just be about DFG, it would be an oversight of a wider range of housing issues, including adaptations, telecare, equipment, planning policy, anything kind of housing related that feeds into the care system. So we said that one of these boards should be set up in every area, similar to the local safeguarding children's boards, which gives you quite a lot of flexibility in terms of how you set those up, and that there should be a metric as part of the Better Care Fund going forwards on how DFG is spent. Because DFG fund is probably around 10% of the Better Care Fund now, but there's no metric associated to it in most areas. So this would link in with community equipment. Because community equipment is, I suppose, kind of smaller adaptations. It just helps to join the whole thing up, and that there should be a policy about how all this fits together in every local authority area. So from a commissioning point of view, what we said was that if you've got somebody that needs to stay living independently in their own home, and you want to get to the outcome that they can continue to do that, and don't need to move into institutional care, so that's either residential care, nursing care or hospital, then there's a range of primary prevention interventions you could do, from lifetime homes, decent home adaptations, planning policy, something like an adaptations register. But then there's a range of secondary prevention, some around the person, reablement, care and support, and then a whole range of things around the property, so things like help to move, home repairs, major adaptations, assistive technology, equipment. And if we can get those working properly and joined together and person-centred, then you should need less care and support. But it does need that strategic oversight that a local health and housing board would provide to make that work effectively.
Okay, so actually before we go on to the spending review there, Paul, I mean, that's very interesting. So that intention to sort of join up potentially disparate aims and objectives and planning cycles and this, that, the other across different government departments and sometimes at local level is part of this sort of wider integration agenda, and as you said, around the person. Very important really. And I'm just looking at the chat kind of so far. You've all said hello to each other. Clay, you were a bit worried you were alone for a moment. Well, you're not, because there's 31 of you online. So, I mean, already to me, I'm thinking, how is this sort of experience? Paul will be going on to this in some detail, but how is this experience locally? Has this intention to join things up been captured and replicated locally? Maybe as the chat continues, you'll be identifying things that are working and not working in your areas that you can share with your colleagues and maybe later offline as well.
Yeah, absolutely. I think there's some areas that have really got it cracked and got most of this already working, but there are an awful lot of areas, particularly county and district areas, where there is a real disconnect between the two.
Yeah.
Just in terms of where kind of the DFG review came from and the extra funding, if you remember, it came about as part of the spending review in 2015, where the Chancellor at the time talked about supporting more people or preventing more people needing to go into a care home by 2019-20, and that actually this year DFG will be over 500 million for the first time. So that, in theory, should fund 85,000 home adaptations, and then the idea is that 10% of those wouldn't then need to go into a care home at some point. Whether that's actually factually correct, and there's the evidence to prove that, I'm not entirely sure, but it does give an example that if you're spending more on home adaptations, then less people will be moving into residential care going forwards, with the savings and the well-being improvements that comes with that.
Actually, yeah, then, Paul. So, if anybody out there has got kinds of experiences about sort of the impact of that kind of funding in that way, then do share it.
Yeah, I think, Kate, that's a good point. I think there are some local authorities that really work together as part of a joint system, and there are some counties where that works really well. But then there are some areas where DFG just pays for showers, stair lifts and ramps, and it's not really particularly integrated with the rest of the system. Yeah,
and I like that message from Kate as well, about the importance of simply getting on with things, not waiting for government direction. Especially because all our work at SCIE is that one size doesn't fit all. Different ways of working in very different environments and localities can work. Some are transferable, some are not, but certainly don't wait for direction.
Absolutely. And this is just a slide to show some of the residential care costs. That the average stable facilities grants around 7,000 or 8,000, and kind of residential care costs from 30,000 odd upwards. And particularly for children who are at risk of becoming looked after, 30, 40, 50,000 pound adaptation can quickly pay for itself. And some of the things that you could do to use some of the money a bit differently, these are the rules and regulations that govern DFG, which were introduced in 1989 originally. So it's nearly 30 years old, but there's a set of legislation and regulations and guidance that sit under that. But what there also is the regulatory reform order. And what that regulatory reform order does, it breaks the link between the funding and the legislation. So what the government said was from 2008-09, if you have a local policy that sets out how you want to use your allocation of DFG funding, then you've got pretty much discretion to do whatever you want with it. As long as you've produced a policy, you can do a wide range of other things with the funding. So this are some of the examples that some local authorities use, and be interested in if you've got different examples to pop them in the chat box. So things like revising or removing the means testing, a lot of local authorities do. Topping up grants over 30,000, supporting hospital discharge, doing preventative adaptations, for example, for people with dementia, maybe carrying out repairs, adaptations on prescription, quite a lot of arguments sometimes between counties and districts about when an adaptation is around about £1,000. Sometimes it's social services, sometimes it's the housing department. If you could pool the funding, then it should work for both. And then you could also help to support people to move. So if their home's not feasible to adapt, you could actually help them to move to somewhere more suitable, like extra care housing, supported housing, or even just a bungalow down the road. I think I have seen some examples of hoarding services. I think it's one of the examples that does cost health quite a lot of money, and actually spending a bit of money in terms of supporting someone with a hoarding disorder. I think it's not just about cleaning up, it's also about the ongoing support that would need as well. So why measure some of these interventions? I'd be interested on your thoughts on why you measure and what you measure at the moment, but some examples, kind of finding out how you're progressing against the impact you want to achieve, learning how to improve your services, using it to secure the funding, and quite a lot of DFG funding has been increased every year, so the last 2 budgets there's been extra funding. So if you're showing that you're spending well, it's much easier to kind of get that funding and use it. I think it inspires staff and helps them to improve their work, raises your profile as a service, and it contributes, if you share it, with the knowledge of what works that we could kind of share in seminars like this going forwards. So what I was going to go on to was how you would use some of these measures as part of a theory of change. So a theory of change is something that can help you understand how you work together to achieve your aims. And it brings this process of change to the forefront. So it's not about just capturing measures for the sake of it. It can make your improvement projects more effective. It can help you communicate what your aims are. And I think it encourages you to engage with the existing evidence base and look at what works and what doesn't. So, theory of change, change models, logic models, kind of have a range of different names, but they all work basically by starting with your impact and working backwards. So, if we kind of took the example from before that we want an impact of less people going into residential care, then you work out what outcomes you need to achieve to achieve that impact. What outputs you need to generate to achieve those outcomes, what activities you need to do for those outputs, and then what inputs you need to put into the system. Which all sounds a bit jargon, I know. So here's an example of how it would work potentially for a DFG process. So this is a very simplified version. But if you want an impact of 20 fewer people in a care home, it may be that you have to make 200 people feel safer in their own home. And to do that, you need to carry out 240 adaptations. And to do that, you would need to carry out 10 cases per month using 2 surveyors and £1 million. So that's kind of working back from the impacts to what inputs you need to make that work. And then kind of once you've set up that theory of change, you can then start to work forwards again and see if your system is working. So what we're going to do over the next 20 minutes or so is look at each of those stages and see what things that you think you could capture that would be part of your theory of change going forwards.
And as you say, there's some good conversations emerging between yourselves at the same time as well. Kate and Claire there, and how you operate in a county-wide stroke district system, get the benefits of that best effect and perhaps some consistency across the county. And Kate, yeah, you've just said we are listening honest. We believe you, don't we?
Absolutely. Absolutely. I just saw Claire's comment about 2 tiers, trusted assessors, OTA posts, which is exactly what this case study looks at actually. Started with a county council area that has 5 districts, and fairly typically they had multiple teams, each with a separate manager, various offices across the county, different access points, waiting lists throughout the process. So not surprisingly there were competing priorities, no overall ownership, and they mapped out their customer journey around a room and post-it notes. And they had 220 post-it notes posted around the room working out how they operate at the moment. And I guess not surprisingly, 35% of people dropped out somewhere along the process. And this was how they used to operate. They had, if you needed an adaptation, you contacted social services. If you got through the social services contact system, it would be referred on to the occupational therapy team, who would, after a waiting period, make an assessment. And assuming that assessment was for some sort of adaptation, it would be passed on to the local home improvement agency that would help with the application. Once they completed the application, that would be passed back to the local housing authority, who would approve the grants, and then a contractor would carry out the work. And that's typically how around 60 to 70% of DFGs are processed at the moment. And I guess most of you probably recognise that as the traditional process. But what they moved towards was having an integrated home modifications team where they seconded OTs and housing staff into one joint team where they all sit together. And now if somebody wants an adaptation, they contact this team directly. There's a triage and initial assessment process. And depending on that triage, it's either allocated to an OT for the more complex cases who works with a technical officer to develop the solution. And then between them, they handle the process from start to finish. Or if it's a more simple case, it's transferred to what they call a housing assessment officer, who's part caseworker, part technical officer and part occupational therapy assistant, and that person then handles the case from start to finish. And the DFG is approved and the contractor carries out the work, but as far as the person receiving the service is concerned, they have one person throughout the process, whichever way they go. And part of what they did was some benchmarking and looking at some of the metrics, and a key one was how quickly they got through the process from start to finish. And at the start of the process, they were towards the right-hand side of the graph in terms of time from start to completion, and they worked at it until they were the quickest in their benchmarking group, and they've continued to work on it since and got it quicker. This was about 18 months ago, this chart. So there is a lot of potential there for integration, joint working, and really improving the system. And it did take them 5 years to get there, but I think it's really good to see that they've made a real difference to how these things work, and that these kind of integrated systems, rather than having an OT system and a housing system that's somewhere bolted together in the middle, is definitely the way to go going forwards. So they have the shared vision goals, strategic direction, single access points. Their 220-step journey is now down to 22, and only 3% of people fall out of the system. So they're seeing a lot more people and a lot quicker. So good to see that there's some fast-track assessments going on in some areas of the country. I think a lot of you will be interested in a document that will be coming out from the Royal College of OTs quite shortly around the need for assessment and how to do assessment differently. So if we work through some of these metrics, and because if as we go along you start typing any of your suggestions for things to measure. So if we start at the right hand side again where we had that diagram before, and if we kind of assume that the impact, and that this is what the Chancellor set out in 2015, was to prevent 8,500 people from needing to go into a care home by this year. Now that's, I think, slightly difficult to measure in many areas, particularly if you've got a mix of self-funders and social care funded people in care homes. But that generally assumes that 10% of DFG recipients are prevented from needing residential care. And some of this came from a Freedom of Information request that we did probably 3 or 4 years ago now, that showed that if you use the NHS number to link DFG and care data, it does show that people who've had a DFG do tend to move into residential care much later than those that haven't. So I think there is definitely a link there if you can start to join your DFG or housing data with your care data. And if you record the NHS number in both, that's a good way of linking the systems together. So if we work back from that impact, and again you may have different impacts that you want to use locally, what outcomes should we measure that then show us or deliver us that impact? I think outcomes are sometimes a little bit misunderstood, but I would say that an outcome is something that's personal to the person that's receiving it. So I know more, I feel different, I act different, I have a chance I didn't before, I am financially better off, my health is improved. It's something that means something to the person receiving the service.
I think what's interesting about the outcome types that you set out there, Paul, as well, it's all about holistically about the whole person, isn't it? It's not about a particular service vis-a-vis another service. And so kind of measuring the impact of particular interventions can be quite complex. But in a way that's fine, because this is what we should all be looking for as we work together in the more integrated way that you were saying at the start of the presentation.
Absolutely. I think if you're a disabled person wanting to live independently at home, having a level access shower or stair lift is probably only part of the solution you need. There'll be other things like care and support, maybe telecare, maybe a grab rail outside the front door that may impact on your outcomes as well. So it is difficult to separate them, and actually looking at what the overall impact of the person is I think, the right way to go. So, any thoughts on what outcomes that you would like to measure, or if you're currently measuring outcomes, that'd be excellent.
Come on, top away.
Ollie asked about the data about people going into care homes. It was a report on the Foundation's website from a Freedom of Information request. And it's also mentioned in the paper that the Department of Health circulated on prevention towards the end of last year. That was the evidence they cited around adaptations being good in terms of prevention. Okay, suggestion from Kate around accessing my share independently.
There's a specific request from Ollie about what data you may not pull, but again, you know, you are resources yourselves on this and have information indicating that people with DFG do go to care homes later.
Yes, it was very much a freedom of information. The slight difficulty with freedom of information request was that only around 20% of local authorities could join up their housing and care data when we did it. Hope that will be a bit better now, but if you can. There have been other studies that have shown similar results. So if you can find a friendly analyst who will join up your two systems, you can get quite good data from it.
And there's an interesting one from you, Claire, about removing the need for a care package as the house is now adapted. And again, it's kind of seeing the person kind of holistically and recognising that we're all motivated by trying to help people live, in confidence, comfort, independently.
I think one of the other bits that we found from the Freedom of Information request was that only around 20% of people having adaptations have a formal care package with social care. A lot of it is informal care, and there's been some evidence from Australia that actually its adaptations support informal care much more than funded care, and preventing carer breakdown is probably its biggest impact in terms of as Rhiannon says.
Yeah. And there's a bell being rung between Claire and Kate as well. Claire saying, snap, Kate. Well, you're supposed to be contributing to this webinar, not playing cards, but lay off.
So, once you've got your outcomes, then you can start to think about what outputs you need to deliver to generate those outcomes. And these are just some of the examples that we found from doing the DFG review. So in terms of applicants by age, in terms of DFG, you probably won't be surprised that around 60% are older people, around 30% are people of working age, and 10% roughly are children. Actually, the percentage of older people is slightly falling each year. By tenure, most adaptations go to people who own their own home. Around a third to tenants of housing associations, and a small percentage go to private tenants, which I suppose is slightly at odds with tenure now, because there are more private tenanted houses in England than there are social house providers, and there's probably something around housing association tenants get more support than private tenants do. And in terms of disability, 90% of DFGs go for people with physical disabilities, and very few for other impairments such as sensory impairments, learning disabilities. And grant uses, 55% of DFGs used to pay for level access showers, around 25% for a stair lift of some sort, 10% on ramps, 3% on extensions and 7% on other bits and pieces like through-floor lifts. So you can see the vast majority of DFG funding, kind of 90%, goes on showers, stair lifts and ramps. But that's kind of the tip of the iceberg, I think, in terms of what DFG does and kind of the outputs that we need to measure. So it'd be interesting to see, but what do you measure locally? And Colin, in terms of health conditions, we did ask that as part of the DFG review, but it's not something that's been collated.
There's 2 or 3 contributions there as well about trying to keep a focus on what, especially top tier commissioners, I'm sure it's the same in single in unitary authorities as well, what the commissioners are really looking for, what enables them to invest in particular services, and that's kind of, high level care act outcomes, prevention of recurrence, and I suppose, reduced costs and evidence of increased independence from people using different blends of services.
I think there's probably a disconnect in many areas now between people who are delivering DFGs and kind of knowing what it can do, and commissioners understanding what it can do and how it can impact on the rest of their services. So I think there is some work to join those two together and see how we can make best use of DFG funding going forwards.
As Paul touched on something there, how do you think the level of understanding is in your locality about the contribution of DFG?
Yes, North Somerset don't measure anything? Okay. Yeah, I think kind of Ollie's point around being more preventative. I think a lot of that, most DFGs are before a person reaches Care Act eligibility. So I think that there is a certain level of preventative nature of them that follows through. But I think sometimes if there's a social care contact centre involved, sometimes people may be filtered out at that stage because they're not Care Act eligible, where they would be eligible for a DFG. Don't know if anybody's got any experience of that.
And that link to readmissions to hospital, Jay, is obviously kind of, very topical. Pressure on the acute services, anything that's positioned as reducing that is clearly a button to be pressing.
Absolutely. I think kind of the key there is speed. DFG is not always known for its speed of delivery, and obviously if you wanted to get somebody out of hospital or keep them out of hospital, then a speedy solution is part of what's needed going forwards. So quite a nice list of measures there from Kevin.
Yeah.
So reducing formal care, reducing informal care. I assume, Kevin, that's measured at the point of completion, or is that measured at some point afterwards? Yeah, I think, Anna, that's that point in difference between outputs and outcomes. So we need to measure the outcomes for people, and then part of this theory of change process is what outputs we need to deliver those outcomes. Yeah, single point of contact, definitely critical.
And Cheryl's emphasis there on signposting rather than necessarily assuming that the service that you're running, as it were, is the solution.
Absolutely.
Yeah.
So we've gone through some potential outputs. So what activities would you then measure or be useful to measure in terms of delivering those outputs? So we said this was the traditional DFG delivery that county used previously. So it may be You count the number of people contacting social services, number of OT assessments carried out, number of applications made, number of grants approved, number of grants completed. I guess fairly traditional measures. So is there anything else that you think would be really useful to measure as part of your process? I think, Ollie, in terms of single point of contact, it's fairly limited. And one of the things we found is on local authority websites, it's usually really difficult to find information about DFG. And even if there's information there, it's almost impossible to find a telephone number in many cases. And a lot of the council websites are really out of date. Be interested to see if anybody here has updated their website recently. But I've been to some, and contact details are 3, 4, 5 years out of date. Home improvement agencies that used to deliver the service are still referenced, even though they stopped delivering the service 5, 6 years ago sometimes. I think a single point of contact is probably easier to find in a unitary authority, but not necessarily the case. And quite often we've seen quite a number of unitary local authorities that were quite joined up and integrated have been have had their kind of housing and OT teams separated, and in some cases moved into different towns. So it doesn't always go that a unitary is better than a district and county situation, I think.
So do you find that it works well in North Somerset, that, Gail, given what Paul's saying? Is the learning for elsewhere? Unitary authority, we talk quite a lot about councils and districts, haven't we?
Yeah. Yeah. Okay. So once you've recorded your activities or decided which activities you're going to measure, you can then think about what inputs you're going to measure that go into the system at the start. So I suppose fairly straightforwardly, how much capital funding do you need? That's usually provided by central government, and usually assume that that would do the job. But actually, if you work through this theory of change, it may be insufficient, or it may be more than you need. And then starting to think about how many staff do you need to actually deliver this service, and what roles do they play or perform. So it may be that there's some transformation or reorganisation there in terms of what roles you need to deliver an effective service. And actually, if you've measured all the other metrics as you've gone through, it'd be something that you could then measure and see how it's working as well going forwards, particularly if you're moving from a traditional service to one that's more integrated. So any other inputs you think we should measure? Yeah, I think Juliet would agree about primary health. It can be difficult to get social care involved, so moving that onto primary health is another challenge for us, I think. But that's part of it being in the Better Care Fund, I think, and why it's there is that there's a big potential for it to link with health and social care more widely than it does at the moment.
Gail, you're a unitary, by the way, North Somerset. I know because I applied for a job there once and was turned down, but I'm not. I'm not bitter.
Yeah, the cost of adaptations do vary considerably. I think there are kind of pros and cons to DFG being a capital grant, and that there is some flexibility around how you can use it as, I suppose, kind of revenue type fund through fees and other methods. Usually depends on the willingness of your Section 51 officer. discretionary funds haven't traditionally been measured by the local return for DFG, but we have captured some of that through freedom of information requests, and there will be a new data system that the government use going forwards that can capture some of this information a lot better. RROs don't necessarily have to be revenue, and there are some interesting cases where there have been swaps in terms of social care needing capital, and then using some of the other revenue in the Better Care Fund to do a swap for that. Or sometimes you could give some of the capital to a housing association for their adaptations, and then they would fund staff as kind of a revenue resource.
I mean, I guess that's the 64 I should say, $1,000 question, Juliet, isn't it? How do you know you're getting value for money? And again, I think we're back to what Paul was saying about trying to look holistically as the whole person there, really. And one or two of you have indicated that, you know, investment in DFG funded intervention can maybe offset and more the cost of other longer term, more expensive interventions through care packages and so on, really.
Absolutely.
So it's very important seeing the totality and not applying value for money calculations on bits.
I think value for money in terms of DFG has traditionally been how cheaply can we deliver a shower adaptation, or how cheaply can we install a stair lift. Or actually value for money is more about how does this impact on the person, and what does it mean for the longer term for their health and social care and their own personal well-being. Yeah, agree with you, Anna, on terms of discretionary funding. We've certainly recommended that that's captured going forwards. Interested to know if anybody's done any social prescribing with GPs in terms of adaptations and whether you've got that to work.
Yeah, that's really interesting, with Jay saying there that DFG referrals are not frequently coming from GPs, and trying to understand the reason for that. Is it because GPs are giving information, advice and diverting people elsewhere, or are they missing what needs to be referred? I don't know, to be honest.
It was Social Prescribing Day yesterday, so I'd be interested to see if any of you have done any social prescribing around DFG.
Yeah.
Okay.
Well, Kevin there's a similar experience, poor referral rate from GP surgeries.
Yeah.
Trying to get underneath that, isn't it, and understanding why that's the case, really.
Yeah, I think you're right, Kevin. There's a lot for GPs to remember.
Yeah. So how do we provide information in a way that's quick, easy, accessible and so on, which relies less on them having to remember, I suppose?
And in some areas, there's a housing support worker would be based in a doctor's surgery, so it's not actually the doctor themselves.
Right. And absolutely about self-funders, Juliet. It's not just about DFG either. I mean, I think we've got, you know, a huge issue across the whole of the care and support system about how we provide information and advice for self-funders.
Yeah, absolutely. So I kind of always say that DFG is only part of the solution. Yeah. And that as you kind of set up these systems, there'll be wider impacts that you can feed into your measures that would hopefully take into account self-funders as well. But in terms of the theory of change, here's just kind of a very simple example of what measures you may look to capture through a system. So I suppose working from the start this time, if you know what staff time and grant funding you've got, that should then lead you to understand that the amount of advice, information and grant applications would be generated, what that would lead to in terms of outputs, what outcomes that would deliver, and how that would then affect your impact. So you could measure that process going forwards, and then you would revise your theory of change based on the evidence you generate. So very much working, you develop your theory of change working backwards, and then in operation work it forwards again.
Yeah.
So that's the theory of change. I hope you'd find that useful in terms of understanding, I suppose, a little bit more about how you could use metrics going forwards rather than just the traditional ones of perhaps outputs and how many grants you deliver, to actually get a better idea of how the system's working and how to improve it going forwards. As I said at the start, one of the recommendations from the DFG review was a transformation fund that each local authority would have to improve their services going forwards. And I think this would be a key element of how you would use that fund to improve services, make them more integrated, support more self-funders, and actually get people to a position where they can live independently at home without having to wait months or years sometimes for an adaptation to be delivered. Great, they're down to 100 days in Norwich.
Yeah.
There was a local government ombudsman report last week where somebody had waited 18 months for an assessment and they'd been given or awarded £50 per month compensation. So if that became more broadly applicable, you'd soon spend your DFG budget on compensating people for delays rather than actually delivering the service.
Okay, so have you more questions for Paul, or questions to each other? It's been fascinating for me sitting here looking at the various kind of contributions and the way that some of you made connections with each other as well. So are there other comments and questions?
I think, as Kevin's demonstrated, Norfolk have had an integrated team for a little while, and actually having those policies that kind of work across councils, work across commissioning areas, really does make a difference in terms of focusing minds and funding and everything else in terms of delivering better services. I think where people, there are so many local authorities that just kind of go on delivering DFG from year to year in the same way, not really knowing whether it's good, bad or indifferent, and unless you kind of start to understand kind of how well your service is delivering, it's really difficult to start improving it, I think. You can mention the Green Paper, Claire. I think it's I think it's fairly soon. By fairly soon, I'm not quite sure what that means, but I understand that some of the recommendations from the DFG review will feature in the Green Paper. Natalie, if you want to get in touch with foundations, then we've got lots of RRO policies that we can share with you.
And Anna, yeah, that variation from 1 day to 6 months for getting assessment is absolutely incredible, isn't it, really? You know, maybe there are opportunities to examine, you know, processes in there's lots of tools and ways of doing that, really, removing blockages and so on, because those sorts of delays, especially if somebody's you know, is elderly and, you know, probably possibly deteriorating as well, can be you know, can have a dreadful impact, really.
I think the other thing that we're looking at on RRO policies is if there's a group of local authorities that all want to develop one, setting up some peer groups so you can work together on developing a policy. Certainly doing that in London, and if anybody wanted to join, I'm sure there'd be an opportunity to do that as well. Yeah, Section 151 officers, there is some guidance around capital and how to use it, and we've continued to push CLG for more advice on that. But at the moment, it does depend a lot on the discretion of your Section 151 officer, unfortunately.
Okay, Kevin and Claire are typing, and I think we're moving towards a natural conclusion for this webinar today. So we'll just see what these last 2 or 3 contributions are. Yeah, understanding discretion, Claire, is very important. We've recently come up with the phrase legitimate variation, working with one county. Everybody thinks their own particular area is absolutely unique, but actually, is it? Yeah.
No, I think kind of going from county to county, it's amazing how similar most of the issues are.
Yeah. So difference can be kind of overstated, really.
Yes. Yeah.
Oh.
I think whether you're looking to second OTs or actually employ trusted assessors may be part of your solution going forwards. Yeah, I think you've got something about leadership or lack of there, Juliet, I must admit. The Disabled Living Foundation provide training on trusted assessors up to level 4, which can assess for things like showers, stair lifts and ramps.
Okay, well, I think we're moving towards a natural end there. Maybe one or two other comments will come in. Remember, you're going to get full recording. You're going to get full recording of this. We'll put it on the SCIE website along with your own questions and comments. And Paul's presentation. I'm very grateful to Paul for the thought and energy that he's put into the presentation today, and the way that he's managed both to give the presentation and pick up some interesting things for himself at the same time, which is pretty impressive, really. Hopefully you've made some connections with yourselves, between yourselves as well. It certainly looks like it from what we've seen over the last 50-55 minutes. So we're going to finish at this point. And a huge thank you for your contributions. It's been great from our point of view, and I hope from yours as well. So have a good day, and have good weekends, everyone. Thank you very much indeed.